everyone. Myself, Dr. Priyanka. I am one of your mentors for StudyMRCPI. So today we are back with the YouTube series where we cover the important modules with their important topics, and we discuss it in a question and answer pattern, and we cover the most important points that are important in the exam point of view. So today I am going to cover early pregnancy module. And always remember that a little progress each day adds up to big results. So first we will be discussing the question and then the answer, and then we will move towards the theory part. So here's the first question. There is a woman who has had an early ultrasound scan and the possibility of a molar pregnancy was suspected with the coexisting twin. That is, there was a suspicion of partial mole. There was suspicion by the sonographer. The woman has been referred to a regional fetal medicine center for further investigations. So, what would be the most appropriate investigation in this case? So, there is suspicion of a partial molar pregnancy, and she has been referred to the regional fetal medicine center. So, is it fetal blood sampling for beta HCG levels for suspected molar pregnancy, or karyotyping of suspected molar pregnancy, or we have to do karyotyping of the mother, or an MRI scan, or serum beta HCG levels? So we know that if there is a case of a partial molar pregnancy, the coexisting twin has an increased risk of having chromosomal abnormality, because we know the karyotype in a partial molar pregnancy is XXY, 69XXY. So here we will choose the answer as karyotyping of the suspected molar pregnancy, okay, as an answer. So first, coming basically to the gestational trophoblastic disease, that's a spectrum of disorder which involves multiple classifications that are divided into pre-malignant and malignant lesions. So what does the gestational trophoblastic disease itself cover? It covers the complete mole and partial mole. So what's the difference between a complete mole is there is no any coexisting twin, and the material, that is genetic material, is there is only from the one side of the parent, and in partial mole there is a coexisting twin. So the karyotype is different. It will be 46XX or XY for a complete mole, and for partial mole it can be XXY or XXX. So in the malignant, because this knowing the which type of molar pregnancy is very important, because the management for both the molar pregnancies is basically a surgical management or for the evacuation of the retained products of conception. But the difference is the follow-up is different for a complete mole and partial mole. Now coming to malignant gestational trophoblastic disease, it also covers a spectrum of disorders which are a little sinister than the gestational trophoblastic pre-malignant conditions. It consists of invasive mole, choriocarcinoma, placental site trophoblastic tumor, and the rare epithelioid trophoblastic tumor. So in Ireland, the National Gestational Trophoblastic Registry is situated in the Cork University. So how do we go about if there is any surgical management of a miscarriage? So here we generally do a histological assessment of the tissues that are obtained from the surgical management of miscarriage to exclude the trophoblastic disease. For those women who are undergoing the medical management of miscarriage, the advice is to perform a urine pregnancy test at least 2 to 4 weeks after the date of miscarriage or termination. So the risk of missing a molar pregnancy, if we do not do a histopathological examination after a surgical management, the risk of missing a molar pregnancy is almost 1 in 9,000. And when we have a suspicion of molar pregnancy in some patient, like any ultrasound findings or any suspicion, if there is the per abdomen, if the period of amenorrhea is more than the her last menstrual period in some cases, in such cases, or if there is a bleeding per vaginum, so in that cases we should take a proper detailed history. We should ask if there is any passage of vesicles, especially in previous history, because recurrence also is present in case of molar pregnancy. and other symptoms, any pain. We need to do a clinical examination, look for the fundal height and her pulse. General examination we need to do, and we need to do an ultrasound examination to look for that is to look for the type of molar pregnancy, whether it's a complete mole which will show the snowstorm appearance, or a partial mole where there is a molar mass which is present with the coexisting twin. And also we need to do serum chorionic gonadotrophin levels, because these values will be very high in case of a molar pregnancy, as especially in case of complete molar pregnancy, because there is no fetal tissue, and all the tissue that is there is are the trophoblasts which secrete HCG. So the HCG values will be very high. So we do HCG, and but the definitive gold standard to confirm a case of a molar pregnancy is by doing the histopathological examination of the products of conception. So that is the one which will confirm that is the diagnostic test to diagnose a molar pregnancy. Some histochemical tests are done to differentiate between complete and partial molar pregnancies or non-molar pregnancies which contain the P57 KIP2 stain. And whenever there is suspicion of molar pregnancy, the histopathology report should be available within the 14 calendar days. So now this is the next question, where there is a 25-year-old woman who is diagnosed with a complete molar pregnancy and is scheduled to undergo surgical evacuation in third theater. So we know the management of complete mole surgical evacuation. So now she's undergoing the procedure, and which is the only acceptable management plan in her case. So using cervical priming, using prostaglandins, or routine use of oxytocin infusion, or selective use only when there is a case of a life-threatening hemorrhage, or routine use at the end of evacuation, and IUCD, that is intrauterine contraceptive device for long-term contraception immediately post-procedure. So what do you think here the answer can be? So the guideline says that we can use oxytocin infusion in case of life-threatening hemorrhage. The option C is the correct answer, because there is theoretical risk of embolization of the trophoblastic tissue, and hence routine use of oxytocin infusion is avoided, and only if there is a case of life-threatening hemorrhage. So for that, in that case, we use oxytocin infusion. So how is the follow-up for a complete molar and partial mole pregnancy? The follow-up is little extensive for complete molar pregnancy. So when the suction and evacuation, when the procedure is done, after that we do beta HCG follow-up every weekly until it normalizes for 3 weeks. So until normalization is achieved for 3 weeks, we do the beta HCG every weekly, and then after this consecutive 3 weeks, it has been normal. We see when it has come to normal. So if it has come to normal within 8 weeks, that is 56 days from the date of evacuation of the molar pregnancy, within 56 days, then the follow-up is for 6 months from the date of evacuation. But if the normalization has happened after 8 weeks from the date of evacuation, or after 56 days of evacuation, then we do follow up for 6 months from the date of normalization of the HCG values. And these points are very important for the written exam, because they can ask the question that they can give the scenario that it had come to normal within 8 weeks or after 8 weeks. So what would be the of management plan? And for partial mole, here we do weekly values until normalization, and once they are normal, we just do one test to confirm that the SCG values, subsequent SCG values are also normal, and only one test, which is done usually 4 weeks apart. And if that test is normal, then the patient's follow-up is complete in case of molar pregnancy. As we know that molar pregnancy does carries a recurrence around almost 1 in 80. So in that case, we tell the patient to also monitor for any excessive bleeding, and then we tell them to come and contact us. And also whenever they are trying to conceive for the next time, so if they conceive, they should have an early fetal ultrasound to look for the type of pregnancy, to rule out any molar pregnancy. So an early viability scan is recommended in them. So this was about molar pregnancy. So now this question, there is a 29-year-old woman who is at 6 weeks pregnancy and is diagnosed to have a right tubal ectopic pregnancy by transvaginal pelvic scan. Which one of the following factors would enable systemic methotrexate to be offered as a medical treatment option for the ectopic pregnancy? So here she is already diagnosed with the right tubal ectopic pregnancy. The question that is asked is, of the following criteria, what are the criteria where she is fit to have a medical management that is by methotrexate? So if the ectopic mass size, if it is 5 into 4 in size, so that she does not fit into that criteria because the size is more. If the initial serum HCG is 1000, yes, she can have medical management. If there is presence of fetal heartbeat, so that is also a contraindication for a medical management. If there is ultrasound evidence of hemoperitoneum more than 50 ml, so that is also a contraindication because it signifies that she has is probably already ruptured, and in this case, then we need to do an urge, expedite the procedure of management of the ectopic pregnancy by doing a surgery, that is laparoscopy or a laparotomy. And if the woman has had a previous salpingectomy, so further salpingectomy surgery is contraindicated. So in this case also, the medical management is not indicated in this case. So the answer here is B, that is initial serum HCG of 1000. So after a few slides, we will come to know what is the criteria of expectant management, what is the criteria of medical management, and what is the criteria of surgical management. So first coming to the ectopic pregnancy, what is ectopic pregnancy? When normally the pregnancy should locate when there is abnormal location of the pregnancy, then it is called as ectopic pregnancy. So it is not located in the normal intrauterine locations. If it is angular or interstitial, or more like on the interstitial part, or if it is in the cesarean scar pregnancy, which is more commonly seen nowadays due to rising rate of cesarean sections, or if it's a cervical pregnancy, if it's an ampullary tubal ectopic pregnancy, or if it's ovarian tubal ectopic pregnancy, these are the types of ectopic pregnancies. Very rarely we can see a primary abdominal ectopic pregnancy. So how do we diagnose an ectopic pregnancy? We do a transvaginal scan. Transvaginal, which is the best imaging modality to diagnose an ectopic pregnancy, especially by an experienced sonographer to locate the pregnancy. So what we usually see in transvaginal ultrasound, that there is an adnexal mass which we move separate from the ovary. Okay, and in that mass we can see either a yolk sac or a fetal pole, or we may not see fetal pole or yolk sac, and there will be this mass and with an empty uterus, which will have high suspicion of this tubal ectopic pregnancy. And to guide the management options, we do serum beta HCG values. Okay, so serial serum beta HCG, to say more precise. So it's a combination of transvaginal ultrasound scan plus serum beta HCG levels measurements we do, and also we do take a proper clinical history and do check the woman's do the examination to look which criteria is fit for her, whether she is good for expectant management or medical management or surgical, by doing all the history, clinical examination, and her investigations. We decide which management is best suitable for her. So what are the differential diagnoses? Which other conditions may mimic like an ectopic pregnancy? So we can divide them into gynecological and non-gynecological conditions. So like threatened miscarriage, which can also have complaints of pain, abdomen, and spotting PV. Even molar pregnancy can also mimic ectopic pregnancy. Ovarian torsion, which can also be present with acute abdominal pain or a tubo-ovarian mass, and even non-gynecological conditions like ureteric calculi and acute appendicitis can also mimic like an ectopic pregnancy. So how do an ectopic pregnancy present? The clinical picture is variable. Some patients may be asymptomatic, and incidentally, an ectopic mass is seen on the ultrasound. While most common presentation is there is a triad of amenorrhea and vaginal bleeding and lower abdominal pain. Some may have other GI symptoms like diarrhea, vomiting, dizziness, and almost 5% of them may go into directly hemorrhagic shock. That can be the presentation which can be seen. So the signs will depend upon how the patient hemodynamically stable is. If the patient is hemodynamically unstable, we can see the patient is hemorrhaging, we can see signs of pallor, tachycardia, and hypotension. Also, due to intra-abdominal hemorrhage, it can lead to the irritation of the diaphragm and which can cause shoulder pain. And on exam, we do a physical examination and speculum examination and also a bimanual examination, and there will be cervical excitation which can be seen. And we do in the investigations, we do a transvaginal scan and serial serum beta HCG levels. So this is the image representation of the signs of the clinical presentation of ectopic pregnancy. By there will be pelvic plain, vaginal bleeding, tender cervix, which can be seen. Now, what are the criteria for different types of management? So there are three types of management of ectopic pregnancy. One is the expectant, then is the medical management, and the third is the surgical management. So for expected management, the patient should be asymptomatic. There shouldn't be any pain, preferably, and the HCG value should be very low and falling. The patient should understand what the condition they are having, and they should be able to return to follow-up, and they should be compliant with the follow-up. This is most important. And the HCG values, according to the new guidelines 2024, can be less than 1,500. The patient can have expected management, and the mass size can be less than 3 centimeters. We can offer them expected management. So it's not only one of this. There should be all the combinations seen. Like the SCG should be less than 1,500. Also, the mass size should be less than 3. There shouldn't be any cardiac activity. Patient should be hemodynamically stable, and also they should have access to 24-hour access to the hospital in case of emergency. And how do we proceed in expected management? We do serial HCG levels, and serial HCG levels every 48 hours, and we see how is the trend, and if they are falling over 3 measurements, then we do weekly beta HCG monitoring until it is non-pregnant values, that is, it is less than 5 international units per liter. But if the patient becomes symptomatic, or if there is a rising trend in HCG levels, or in that case, we abandon the expected management, and we may need to do other types of management, preferably the surgical management. Now, in case of medical management, in medical management, we use systemic methotrexate as a drug because it is a folic acid antagonist, and it inactivates the enzyme called as dihydrofolate reductase, that is DHFR, and hence this enzyme again is responsible for DNA and RNA synthesis. So if we inactivate this enzyme, it inhibits the DNA and RNA synthesis and prevents further proliferation. So the half-life of methotrexate is 8 to 15 hours. Now the new criteria is if the HCG values are less than 5,000, we can choose to give methotrexate. The guideline says that the methotrexate is more successful when the values are less than 3,000, but we can give even if the values are up to less than 5,000. Or if the adnexal mass is less than 35 mm and there is no cardiac activity, and again the patient is compliant for follow-up, and the patient is hemodynamically stable, and main important thing is the patient doesn't have any contraindications for methotrexate, which is very important. So what are the contraindications that we need to rule out first? First is the any pre-existing blood dyscrasias, like any bone marrow hypoplasia, any pancytopenia, because these are the side effects that are going to happen if we give methotrexate. So if the patient is already having pre-existing blood problems, then the patient is not a suitable candidate for medical management. If the patient is having infections like HIV, TB, or if the patient is breastfeeding, or if there is active pulmonary or liver disease, or if the patient is receiving any live vaccines, in this case, or if there is sensitivity to methotrexate, in this case, we avoid medical management. Now, how do we do medical management? So we give a single dose of methotrexate, the dose of 50 by IM injection, and we check beta HCG values on day 4 and day 7, and we see how is the trend. So if there is less than 15% decrease in HCG, we perform a TVS scan, we rule out any cardiac activity, and we repeat the dose of methotrexate. And we repeat the HCG values until they are the non-pregnant range. So the guideline says that those who are receiving methotrexate, that is medical management, so at least 15% of them will require a second dose of methotrexate, and almost 7% of the women who are receiving methotrexate will have tubal rupture. So this all should be explained to the patient, and if they are having a surgical management, then they should have a anti-D also if they are Rh negative non-sensitized pregnant woman. Now, a 26-year-old woman presents with left iliac fossa pain and has a 6 weeks period of amenorrhea. The patient is clinically stable, and ultrasound confirms the presence of left-sided ectopic pregnancy. The mass, there is a 2 into 2 into 2 centimeters pool of free fluid which can be seen in pouch of plug Douglas, and the serum beta HCG values is 3,500. So what's the recommended management? So can she have an expectant or a medical or a surgical management? So she has left iliac fossa pain, means she is symptomatic, and there is suspicion of ectopic pregnancy. Ultrasound has confirmed a left ectopic pregnancy, and we can see that there is free fluid in the pouch of Douglas. So, so it signifies that she has she already is bleeding, and her serum beta HCG values, though they are 3,500, but the patient is already having the signs of ruptured tubal ectopic, but she is clinically stable. So what is the management? So here the management we know now is surgery. So what kind of surgery it is? Is it a salpingectomy, a salpingotomy, or a laparotomy? Like if by doing through the laparoscopy or a laparotomy. So they have written that the patient is clinically stable. So in clinically stable patients, the preferred one is a laparoscopic procedure. And if the contralateral tube is healthy, we can do the recommended method to do is the salpingectomy. So the answer here is A, left laparoscopic salpingectomy if the contralateral tube is healthy. This is what the guideline says. So if the contralateral tube is healthy, the management is to do the salpingectomy. But if the contralateral tube is not healthy, or if the patient has any history of subfertility, in that case, we can do a salpingotomy, but provided we need to tell the patient of the further follow-up that it is required, because it is associated with persistent ectopic, and hence further follow-up is required in case of salpingotomy. So what are the criteria for surgical management? So when the patient is hemodynamically stable, they are having severe pain, or if the expectant or medical management is not appropriate or has failed, and if the beta HCG values are high, that is more than 5,000, if the fetal cardiac activity is present, or if the mass is greater than 35, if the woman denies for expectant or medical management, and it's her preference to have a surgical management, and this is the laparoscopic method is preferred for surgical management of ectopic pregnancy. So, as I said before, in care we do a salpingectomy, especially if the contralateral tube is healthy, or if the same tube there is a history of recurrent ectopic pregnancy. Because again, if we keep the tube, do a salpingectomy, then the recurrence risk is again high. So, in case of recurrent ectopic, or if there is extensive damage to the same tube, we do a salpingectomy. And those women who had completed childbearing, salpingotomy we prefer in those who have not completed childbearing, or like they are a case of subfertility, and also if there is a healthy contralateral tube, and who do not have a healthy contralateral tube. So here we do a HCG follow-up every weekly, and till it reaches the non-pregnant values. And then for those who had salpingotomy, we check for if the values are not decreasing, then we can treat them with methotrexate. So anti-D should be given for those who have surgical management of ectopic pregnancy. And we know that the recurrence risk again is high for ectopic pregnancy. So they should have an early pregnancy ultrasound scan to look for the location of pregnancy at around 6 to 9 weeks. So this is the flow chart by the guideline for the management of an ectopic pregnancy. So it depends upon the various parameters as we discussed, like how the patient is, if they are hemodynamically stable, or if there is no evidence of rupture, they are not having any symptoms, and the values of beta HCG is less than 1500, the mass size is less than 3 centimeters, no cardiac activity, the patient can have expectant management provided they are ready for follow-up. If the HCG values are less than 5000, preferably less than 3000, you can see here they have written that if the serum beta HCG value is less than 3000, we can offer them medical management. But we can consider if the values are between 3000 and 5000. And other things, if the patients are stable and the mass size is less than 3 centimeters, then we can offer them methotrexate. And those who are not hemodynamically stable, or those whose values are more than 5000, having cardiac activity, or come with in collapse, so in that case, the surgical management is preferred. So which of the following statements is correct regarding recurrent miscarriage? So APLA, if found to be the cause of recurrent miscarriage, is untreatable. No. If it is found to be the cause of miscarriage, then we have treatment for that by the combination of aspirin plus a low molecular weight heparin. APLA, the antiphospholipid antibodies are present in 15% women with recurrent miscarriage. Yes, this answer is correct. So the incidence is 15% in those who have recurrent pregnancy loss. Cervical weakness is a recognized cause of first trimester recurrent miscarriage. So cervical weakness is a recognized cause of second trimester miscarriage, recurrent miscarriage. And one of the partners carries a chromosomal abnormality in at least 25. So it is at least 5 to 10% of couples with recurrent miscarriage. And recurrent miscarriage is defined as loss of 4 or more consecutive. So according to the Irish guidelines, so the recurrent miscarriage is defined as loss of 2 or more. Okay, so some bodies may say 3 or more. Some the Irish guidelines say 2 or more consecutive pregnancies losses. We can label them as having recurrent pregnancy loss. So what are the investigations indicated for women following a second trimester miscarriage, which is not indicated in recurrent first trimester loss? So which investigation we are going to send in second trimester miscarriage, not in first trimester? That is the question. Anticardiolipin antibodies for APLA, we are going to send in first trimester. Karyotyping of the products of conception, yes, because these are all the recognized causes of the first trimester recurrent pregnancy loss. So we are going to send lupus anticoagulant, yes, pelvic ultrasound, yes, to look for the pelvic anatomy. And we know, especially the septate uterus, these are the ones which are also responsible for first trimester miscarriage, also to look for any fibroids, which can be also seen by ultrasound. Thrombophilia screen. So thrombophilias are responsible for the second trimester's miscarriages. So thrombophilia screen we are going to do if it is a second trimester, history of second trimester miscarriage. So what is the guideline says for recurrent miscarriage? So it is after 2 consecutive pregnancy losses, we can label them as having a recurrent miscarriage. So what are the investigations that we do in a case of recurrent miscarriage? First, we take a proper history from the patient, ask what is the number of the pregnancy, previous obstetric history, what was the outcome, and if it was the previous missed miscarriage or a spontaneous pregnancy loss, or if there was a blighted ovum. So all this detailed information should be taken, and was there heartbeat, and how it was managed, like was it managed medically, expectantly, surgically, all the details, any complications if the patient had post procedure, and her age, which is very important, the maternal age should be noted down. And as I said, the other history, like any medical history, surgical, previous surgeries, habits, especially because we know if smoking also and drinking alcohol also carries a substantial risk for recurrent miscarriage. So if they do have the history, then they should be referred to the smoking cessation services. And also we should note down the BMI. The healthy should be BMI should be between 19 to 23 or 25. And we should tell them to have a proper healthy diet, and also to avoid any consumption of the alcohol or smoking or drugs. And they should be provided with folic acid and vitamin D, basic dose of folic acid, that is 400 micrograms. And in case if there is special history like obesity or previous history of neural tube defects baby, or any history, they are on antiepileptic drugs, these are the few indications where we can give high dose folic acid, that is 5 milligrams. So, ultrasound, basic 2D ultrasound is recommended mandatory for all cases of the recurrent miscarriage. 3D ultrasound, if the facility is available, the guideline says it is preferred to rule out any uterine anomalies. Regarding MRI, MRI is not the first line option, but it can be considered where the 3D ultrasound is not available, or if the ultrasound is showing some complex malformation. In that case, we can consider doing MRI. Hysteroscopy, we can consider when there is a suspicion of a uterine septum. It is preferred than doing the laparoscopy with hysteroscopy. And if there is any suspicion of Mullerian anomaly, then a scan of the abdominal pelvis to look for the anomalies of the kidneys and urinary tract should also be done. Other investigations like hereditary thrombophilia testing, hereditary, or the NK cells or immunological testing is usually not recommended in case of recurrent miscarriage. Now coming to the thyroid function test, yes, these are recommended to the TSH, the antibody, the free thyroxine levels are recommended to be done. And if there is a special history of the menstrual irregularity, we can do a day 2 to 5 hormone profile, which consists of LH, FSH, and estradiol to look for and also testing for ovarian reserve. And infection screening, but for those who are not symptomatic, is not recommended. So this is the algorithm for the evaluation of patients with recurrent miscarriage. So after 2 consecutive miscarriages, we do thyroid function test and antibodies, thyroid peroxidase antibodies. These are the mandatory tests: a full blood count, and antinuclear antibodies, and thrombophilia screen for acquired thrombophilia, that is APLA. What the test we do is the lupus anticoagulant, anticardiolipin, and beta-2 glycoprotein we do. Can be confirmed by doing a second test 12 weeks apart to confirm APLA. We also do HbA1c. So HbA1c, the guideline says, is selective for especially for those who are having a high BMI or who have a previous obstetric history of gestational diabetes, if there is a high risk ethnicity group, or if there is a family history, or if there is history of PCOS. So in that case, we need to do HbA1c. Transvaginal pelvic ultrasound scan is, and if available 3D facility should be done. Now coming to the genetic part. So it depends upon the woman's age, and also how many recurrent miscarriages she had. So if she is less than 35 years and she had a history of 2 consecutive recurrent miscarriages, so if the products of conception are available, then we can do cytogenetics on the products of conception. But if the pregnancy tissues are not available, then we can perform the couple, that is parental karyotypes. If the woman is 35 years or older and has a history of 3 consecutive miscarriages, and if the cytogenetic sample is available, we can do the cytogenetics on the pregnancy tissues. And if they are 35 years or older and have history of 3 or more miscarriages, but we do not have the pregnancy tissue sample, then we can perform the parental karyotype. So this was all about recurrent miscarriages and the early pregnancy module. I hope this helped for your exam preparation. Thank you so much.